Hello. We are going to be presenting hypertension and cardiac failure in primary healthcare setting. I'm Alupeli Tonjeni, and I'll be presenting with Vuyi Vokwana. Dr. Clifford Ricordo is ill. Hypertension, in its simplest definition, is a cardiovascular disease that occurs when there's a persistently elevated blood pressure, hence the layman term high blood pressure. Blood pressure, as we all know from physiology, is the product of cardiac output and total peripheral resistance. However, it is to be noted that blood pressure can be changed over time due to a variety of conditions. And the primary factors determining blood pressure are the sympathetic nervous system and the renin-angiotensin-aldosterone system and the plasma volume. Blood pressure, as defined according to the EML guidelines, is blood pressure over 140 over 90 millimeters of mercury, measured on 2 out of 3 separate occasions in a minimum of 2 days. The definitions and classifications of blood pressure is that it is graded into grade 1 and 2 and 3, as well as isolated systolic blood pressure. It is important to note that in the high normal group, those people are at a higher cardiovascular risk and also at the risk of developing hypertension. And at this stage, lifestyle modification is of paramount importance. The etiological classification of blood pressure, it is divided into primary and secondary classification. Primary hypertension accounts for 95% of the cases and is also known as essential hypertension. The cause is not known. It is poorly understood, but it is most likely the result of numerous genetic and environmental factors. Secondary causes of hypertension can be divided into a systematic approach from head to toe. Starting from the head, in the endocrine system, the patients can have pheochromocytomas. A pheochromocytoma, it is when the adrenal gland produces too much of norepinephrine as well as epinephrine. This stimulates the sympathetic system. And then we have Conn's syndrome, also known as primary aldosterone, and Cushing's syndrome, acromegaly, and hypothyroidism. In the cardiac system, coarctation of aorta. In the renal system, the most common is renal artery stenosis, as well as glomerulonephritis. With each disease, it is important to note that there are risk factors, and these risk factors should be addressed. Non-modifiable risk factors such as age, a patient with advanced age are associated with an increased blood pressure, particularly systolic blood pressure, because they tend to have atherosclerosis, and this increases the total peripheral resistance. Obesity, high sodium diet, excessive alcohol consumption, and smoking, particularly because in smoking, there is a substance called nicotine, and the nicotine is an agonist on the nicotinic cholinergic receptors, and this stimulates the sympathetic system. Race. Hypertension tends to be more common and more severe and occur earlier in life in people of color, and these are Blacks. Family history. Patients who have a positive family history of hypertension are twice more likely to develop hypertension in their lifetime. Also, if a patient has coexisting disorders such as diabetes and hyperlipidemia. In terms of presentation, the symptoms are rare, hence it is also termed as a silent killer. Patients can present with headaches in the morning, dizziness, and also in severe hypertension, they can present with epistaxis, blurred vision. Sometimes they may also present with a CVA. The signs can be elicited when a patient just has an elevated blood pressure. Others can be elicited if a patient has hypertensive retinopathy. And when you examine the patient, they may have a displaced heart laterally. And if you do an ECG, they'll have a left ventricular hypertrophy. It is important to also look at the measurement of the blood pressure. As we all know, blood pressure tends to be measured incorrectly in the clinics most of the time, because no one asks the patient whether did they smoke, did they drink caffeine in the previous 30 minutes. It is of note that we should highlight that patients must be in the sitting position for the least 5 minutes. The arm must be supported in the horizontal position or mid-sternal level. The arm must be bare and at the heart level. And the patient, with emphasis, must not have smoking or had caffeine or had a vigorous exercise in the previous 30 minutes. And you must use a cuff that covers 2/3 of the upper arm. Now we move on to the complications of hypertension. Hypertension has the following target organ damage. It can affect the brain, where a patient can have cerebrovascular accidents, can affect the heart, where they can have left ventricular hypertrophy or cardiac failure. In the eyes, they can have retinopathy, and in the kidneys, they can have renal failure. And in the vessels, they can have peripheral vascular disease. The investigations that should be done at diagnosis, the patient should have a urine dipstick. And if the protein is picked up in the dipstick, you must send it for a urea and creatinine, as well as the GFR. And you must measure the patient's body, you must calculate the patient's body mass index using the height as well as the patient's weight. Measure the patient's waist circumference, HT, because patients can sometimes have diabetes. It is of paramount importance that you must do an ECG, even though in most clinics, ECGs are not available, and the fundoscopy. Yearly investigations to be done, urea and electrolytes, a lipid profile, HGT monitoring, annual urine dipsticks, calculating the BMI, as well as fundoscopy. Other investigations can be done only as per indicated. In managing hypertension, we have pharmacological and non-pharmacological management. To minimize the risk of developing hypertensive complications, a universal goal of antihypertensive treatment is a blood pressure of less than 140/90 millimeters of mercury, regardless of the cardiovascular risk and the underlying comorbidities. In non-pharmacological management, this is according to the South African Hypertensive Guidelines in 2014. It is important that before we commence the patient on any pharmacological management, that we first manage and continue to manage their lifestyle throughout. You consider weight reduction by doing brisk walking for 30 minutes per day for 3 out of 7 days. Moderation of alcohol where there's no more than 2 drinks per day. Complete cessation of smoking, as well as they should reduce their salt intake and introduce a concept called the DASH diet, where you have more vegetables and less fat intake in the plate. Pharmacological management, there is numerous classifications of drugs that we can use. Diuretics, beta blocker, AC inhibitors, calcium channel blockers, and so forth. It is to be noted that with every drug, there is contraindications. For example, patients do not present with just hypertension. They tend to have other comorbidities. So if a patient has gout, it is noted that you should not start the patient on hydrochlorothiazide, which is mostly the common drug that we use as the first basis. Patients who are asthmatic, who have chronic obstructive pulmonary disease or bradycardia should not be started on beta blockers. And patients who have hyperkalemia or renal artery stenosis should not be started on angiotensin converting inhibitors. Now I'm going to be taking you through a step-by-step approach on how to manage hypertension. So we always consider lifestyle modification. Also, as said before you commence the patient on any medication, you should educate the patient about the medication they're about to take, also about the disease that they have, because patients fail to comply because of the lack of understanding most of the time. And you should counsel the patient every time when you're in contact with the patient. So we'll start with lifestyle modification. And if the patient's blood pressure in a month's time is still above 140 over 90 millimeters of mercury, then you start them on one agent. And in this case, if it is a person of color, you can start them on hydrochlorothiazide, provided that there's no contraindications. Then you ask the patient to return in a month's time. And if in a month's time, the blood pressure is still above 140 over 90 millimeters of mercury with adherence to medication and lifestyle modification being emphasized, then you can start them on a long-acting calcium channel blocker. And this will be amlodipine 5 milligrams daily. You start at the low dose. Failure of which you still emphasize on lifestyle modification, you continue with the first line treatment and the second line treatment, and you increase the dose to a higher dose of the second medication. And then if the patient is still uncontrolled, then you may proceed with adding a third medication. What we have seen in the clinic is that patients move from hydrochlorothiazide and then they're then added on atenolol. And this is jumping off steps according to the guidelines. This is what I have just explained. So we move on to the emergencies, where we have hypertensive crisis as well as hypertensive urgency as well as hypertensive emergency. Hypertensive urgency is a severe elevated blood pressure of more than 180 millimeters of mercury over 120 millimeters of mercury without target organ damage. And hypertensive emergency is an elevated blood pressure with target organ damage. I'll start with hypertensive emergency. These patients will need a rapid decrease in their blood pressure, where you use nifedipine 10 milligrams per hour stat to decrease their blood pressure. And it is said that a 25% reduction in the blood pressure is recommended in the first 24 hours. And the patient should be referred to a hospital as soon as possible. And oral therapy should be instituted once the blood pressure is more stable. However, it is difficult to start patients in labetalol infusion in clinics because there's no equipment as well as there is no proper monitoring of the blood pressure. Hypertensive urgency, it is a markedly elevated blood pressure of more than 180 millimeters of mercury or a diastolic blood pressure of more than 130 millimeters of mercury without a target organ damage. Ideally, this should also be treated in the hospital. But unlike hypertensive emergency, in hypertensive urgency, you aim to decrease the blood pressure gradually, slowly over 48 to 72 hours, achieving the goal. So you may give the patient a long-acting calcium channel blocker such as amlodipine, 10 milligrams orally, and then measure the blood pressure in an hour. Then we have a concept called resistant hypertension. Resistant hypertension is when the blood pressure remains over 140 over 90 millimeters of mercury, despite the use of 3 antihypertensive medication in a rational combination at full doses, including a diuretic. However, it is to be noted that patients who came with a blood pressure of more than 160 over 90 millimeters of mercury, this is not the truth, because these patients, their target blood pressure is 150 over 90 millimeters of mercury. So before you classify the patient as having resistant hypertension, you first check the compliance to the medication, you emphasize on lifestyle modification, you ensure that the doses are correct, and once all is above is done, then you can send the patient to a hospital for laboratory and imaging investigations.
Okay, so the next topic is congestive cardiac failure. So this is basically a complex clinical syndrome that results from any structural functional impairment in the ventricular filling or ejection of the blood. In layman's terms, it's basically failure of the heart to pump out blood. So the signs and symptoms vary, but you can have shortness of breath, swelling of the feet and the legs, chronic lack of energy, difficulty sleeping at night due to breathing problems, swollen or tender abdomen with a loss of appetite, cough with frothy sputum, increased urination at night, and confusion and or impaired memory. So there are many different classifications. We've written 3 of them, but they kind of all just mean the same thing. So the first one is systolic versus a diastolic, which is also very similar to the heart failure with reduced ejection fraction and with a preserved. So your systolic heart failure is the same as your heart failure with reduced ejection fraction. And that just basically means that the ventricles have lost their ability to contract normally. Then your diastolic, which is the same as your heart failure with preserved ejection fraction, means that the ventricles are unable to relax normally and your muscles have become stiff. High output failure versus low output failure. High output, you have a normal cardiac output, which is you're unable to keep up with the demands of the body, whereas in a low output failure, you have decreased cardiac output and therefore hyperperfusion of your end organs. So some of the causes, so there are many causes to cardiac failure, and this can be summarized nicely in mnemonic: heart may die. So hypertension, embolism, anemia, rheumatic heart disease, thyrotoxicosis, myocardial infarction, arrhythmias, diet and lifestyle infection, and endocarditis. So there's a severity grading, and we grade this according to the New York Heart Association. So category 1 is basically no limitation of your physical activity. 2 is a slight limitation of the physical activity. So you may just struggle going upstairs or slight incline. Class 3 would be a marked limitation of physical activity. So this you can ask, are the patients struggling to do activities of daily living, brushing teeth, washing dishes, walking around the house? And then class 4, obviously the symptoms occur at rest. So the investigations are then divided into 2 categories: your diagnostic and your supportive. So your diagnostic would be your chest x-ray, and if you all remember, it was also easily summarized into A, B, C, D, E. So you look for cardiomegaly, pulmonary effusion, signs of interstitial edema. On your ECG, you'll look for ischemic changes or ventricular hypertrophy. You'd also ideally do an echo. And then in your bloods, the main one would be a BNP. But to support that, you could also do FBC, UNE, LFT, and a TFT. So in terms of management, the best way to actually manage the patient is to identify the cause and to treat the cause. But at the initial diagnosis, you have to resuscitate and stabilize the patient. So you will do your ABCs. And after that, you give furosemide, 40 milligrams orally or IVI, insert a catheter, and transfer this patient to the hospital for further workup and management. So the first step in the management would be to give a diuretic plus an ACE inhibitor. So you'd start your hydrochlorothiazide, 25 to 50 milligrams daily. If there's a volume overload overload or abnormal renal function, then you can use a loop diuretic such as furosemide 40 daily. Then you'll also start with enalapril at 2.5 milligrams and titrate that to a maximum of 10 milligrams. You also, before using these drugs, you obviously have to rule out the contraindications that we had discussed under the hypertension topic. The second step would then be to titrate the ACE inhibitor and to add a beta blocker. The best one would be to start with Covidolol or use Covidolol, starting at a dose of 3.125 milligrams twice daily. You would increase this every 2 weeks by doubling the dose, and the maximum dose you can then use is 25 milligrams twice daily as well. The titration of this can take several months, and if the patient has discontinued this treatment or you've discontinued it for some reason for more than 14 days, then you have to start, as we have explained under step 1, you have to start from scratch basically. And then atenolol you do not use in cardiac failure, as it is a cardioselective beta-1 adrenergic antagonist in heart failure and basically worsens the heart failure. Your third step would then be to add an aldosterone receptor antagonist, which would be spironolactone 25 milligrams daily. If the patient then remains symptomatic despite your optimal treatment. So with spironolactone, you have to be careful of the potassium, as you could cause a hyperkalemia. So you'd have to monitor the potassium quite closely, and you should not use it together with a potassium supplement, and you do not use it in kidney failure if the GFR is less than 30. So asymptomatic CCF, despite all of this treatment that we have just discussed and mentioned, you then will have to refer to the hospital so that you can start digoxin. And in addition to patients who are referred to hospital, you'd have to do an initial assessment and treatment plan. Patients who poorly respond to treatment, you send them to hospital. People who you suspect infective endocarditis, or ones with a prosthetic heart valve. So these are all the patients that you would then send to hospital, along with ones who are symptomatic and not responding to medication. So hypertension and CCF. So according to Frankham's study, hypertension accounts for about a quarter of heart failure cases. And in the elderly population, it's as many as 68%. So uncontrolled hypertension and prolonged hypertension can lead to a variety of changes in the myocardial structure, coronary vasculature, and the conduction system of the heart. These changes then lead to the development of left ventricular hypertrophy and coronary artery disease. So basically, in summary, hypertension and CCF are a major cause of morbidity and mortality. However, it is still grossly underdiagnosed and undertreated. However, both are very easy to diagnose and to treat. So it's of paramount importance that all patients should be examined thoroughly. Take each consultation as an opportunity to educate the patient about the condition, the importance of compliance, and to emphasize lifestyle modification. There are references, thanks, and then our case study.
Thank you, doctor. Thank you, doctors. It was a very informative presentation.
Thank you.
Any questions? Any questions or that you want to comment on? So the case study is going to be for next week or what? You're
For
going to
next
present
week.
for next week, yes.
Yes.
All right. Any questions? All right. So the group has been very quiet today. I don't know why. They didn't like my voice, or I don't know. Maybe it's my voice or my accent. Can we
Maggie,
close
you did a great job. Thank you so much.
Thanks, Michelle. Yeah. So
It was a quiet group though.
yes, maybe because we didn't split up in the groups and in the rooms, and maybe that's why people felt maybe shy or what to discuss. But I had supporters, and thank you very much for those ones who answered the questions and participated very actively. For me, it was a good session. The presentations were very good. Thank you so much to the presenters. And I'll see you tomorrow. Just make a note that tomorrow the meeting is going to start not at 3, is going to start at 2. Please register in advance. Otherwise, it's difficult to get the link for the meeting. Dr. Petz and Dr. Leon Levin are going to present very interesting cases from Alex Clinic, HIV Clinic. And it's very interactive session. You will enjoy it, I can assure you from now on. And please register and join the meeting at 2 o'clock. Okay, I wish you a good evening. Have a good evening, and yeah, and keep safe. Bye-bye.
Bye, Maggie.
Bye-bye. Bye, everyone.
Thanks, Doc.
Thanks. Thank you.